Good morning, all. I think most of the eminence has already been discussed. We have so many eminent speakers. We have the faculty here. We have people on dais. We have already discussed about the eminence involved in the treatment of the cervical radiculopathy. Let's do the evidence here, what the literature is saying. So we need to clarify certain doubts. How does the natural history look out? Does all patients require treatment? Do all of them go for surgery or non-operative? Still is the first way to treat a patient. What are the surgical treatment options we have? What are the different cages and material? Any one supersedes over the other. Nowadays we have so many debates, fusion versus fusion-less surgery. Let us see what is instilled as far as the literature is concerned. And obviously, in fusion-less now, a new kid on the block, the posterior cervical laminoforaminotomy versus ADR. So it's been discussed quite extensively now that the natural history is quite favorable in cases of cervical spine vis-a-vis a lumbar spine, which often requires a conservative treatment as a first treatment of choice. So as early as 1960, the Lees and Turners were the ones who had studied the natural history and prognosis of the cervical spondylosis. Though they had a small sample size, they reported as good as 75% of them had almost complete pain relief to mild symptoms. Then subsequently, in 1976, this was the first major study involving being a population-based study which had a 5-year follow-up, and nearly 1/4 of them had underwent surgical treatment. Of the non-operative patients, obviously 90% were asymptomatic. Between these two papers itself, you can see a change of tide here. The reason was there was an anchoring bias. You can see papers before 1950s or 1970s for that matter, when the relative anterior approach or the workhorse approach for our anterior procedure or the cervical procedures, which were established somewhere in around 1955 and 1958, till 1970, 1980, it was not very well versed with most of the spine surgeons around the world. Sampath et al. Was the one who did a multicentric study, though it was a non-randomized study. This involved 41 cervical spine research society surgeons involving 246 of them. They had a total follow-up of around 250 patients. 155 of them had underwent surgery and 67%, that is 104, underwent conservative treatment. There was a tilt here that the significant improvement in pain and ADLs were more commonly seen in surgery, and 26% of the one who underwent surgery had excruciating pain at follow-up. Though the improvement in the scores were better after surgery, there was an obvious selection bias. There were severe symptoms. Patients with severe symptoms, they underwent surgery, hence had a better outcome compared to those who were treated conservatively. And obviously, this was the era when the anterior approach was at rampant, and most of the spine surgeons around the world, especially in the North American part, were very well versed with the anterior approach and the ACDF surgeries. So even the NASS guidelines, which is North American Spine Society guidelines, which are very comprehensive guidelines, which takes into account the recent literature, the recent talk, the recent evidence, it suggests that it is likely that for most patients with cervical radiculopathy from degenerative disorder, signs and symptoms will be self-limiting and will resolve spontaneously over a variable length of time without specific treatment. And this was the consensus statement which was given, though here the specific treatment or the duration of treatment which was not mentioned, but anywhere between 6 to 8 weeks was the commonest or the most followed conservative length of the treatment is seen in most of the papers. They also recommended a prospective study, a systematic study, a long-term follow-up in an untreated patients, which is very, very difficult to find out. So you can see the latest paper, the latest big paper is as old as in the 19th century, and nothing we have in the 20th century, because to get a very good evidence out of this untreated patients is very, very difficult, unethical, and I don't think many centers will be allowing it to happen. So this was a path breaker, the surgical approach. This changed the tide. From papers before 1970 had lot of probably some anchoring bias. It's very difficult to validate those studies now, but probably an anchoring bias that not much surgical approaches are there. So you tend to see that most of your patients have started getting better with cervical spine. Here in the morning, we had a debate on the dais itself that now people are thinking about if I can make the patient free with posterior surgery in half an hour, why don't I do that? So the trend of the shift will occur over the time. The non-operative treatment, obviously there are multiple studies suggest that it is still should be followed. Anything between 4 to 6 weeks would be the ideal treatment. The casino trial is actually a well sought trial, well structured, randomized. 2 months of symptoms were included, and they had included a latest questionnaire, but the results are awaiting. I have not, still, last 2 years, I have not got the results of this study, but seems to be on paper a very good trial. Hopefully, for the next couple of years, we'll get the results out and we'll know how the things are going to shape. The latest 2010 NAS guidelines, we don't have a far latest one, but the latest as far as NAS guidelines for the cervical radiculopathy is 2010, and it does recommend a conservative trial as the first line of treatment. The caveat they have mentioned is the emotional and the cognitive factors should be considered whenever you are treating the patient, both medically or surgically. The role of traction as far as the RCTs are concerned is not much. Though the NAS recommendations is not unbiased recommendations, but they are still not clear whether to offer traction or non-traction. Though the paper, this is a randomized control meta-analysis of the RCTs, they have lended support to the traction, but they have further asked for a better studies to validate their consensus statement. Role of epidural steroids, there are papers like Edinburgh et al. Who had studied 40 patients. Then there are paper by from the Southeast Asian countries showing a tilt towards a usage of the epidural steroids. Even the NAS guidelines is the one who suggests that the transforaminal epidural steroids may be considered when developing a medical or interventional treatment plan. Due consideration should be given, though, for the potential complications, and obviously your experience matters. If you are not very well versed with the procedure, better to not do it or give it to your colleagues. Surgical treatment, yes, the main tide over happened at 1955 to 1958 when this huge paper by George Smith as well as Robert Robinson came into picture, where they described the 14 patients having excellent outcomes. Over the period of time, the interbody cages, the anterior cervical plates have changed from threaded to non-threaded to the threaded, from screw back out, not restricted, to a semi-constrained construct. Also, the materials which have changes from the simple bone to the titanium alloy to now the PEEK. PEEK has actually the least subsidence rate as far as the cage is concerned. The bone graft substitutes from autografts are the gold standard, but with the paucity of the grafts, at times we get in the anterior procedure allografts, and the BMP has some role, but again, big RCTs are required to validate the statement. Fusion versus fusion-less surgery, now the world is moving towards the fusion-less surgery. Arthroplasty over the last 3 decades have taken up, but the representations, or rather the evidence, is right from the 1960s that the first lumbar as well as the cervical spheres were used for the arthroplasty. That time the construct was not good, but now from fusion to the fusionless surgery we have gone. It does have advantage of anatomic disc, space height retention, movement, as well as the lumbar lordosis, cervical lordosis. The cervical disc replacement by Phillips does mention that motion preservation at the instrument segments does decreases the chances of ASD. Also, since we are going through a smaller approach, you don't have to go much above or below the disc. The chances of retraction and ease of surgeries is less, and less intraesophageal pressure. Also, less stiffness leads to a less chances of ASD in these studies. The meta-analysis comparing the clinical outcomes between the replacements versus fusions, it is said that ACDF using allograft and plate is superior to TDR in terms of surgical parameters and the ease of surgery, but the disc or the TDRs are marginally more effective than ACDF for functional parameters improvement. They have not included the cost analysis here. Also, the disc replacement being a motion segment, it does allow motion and reduces the chances of ASD at that level. CDR, this is one of the important article, a clinical article written that CDR must remain functional for at least 14 years to establish greater cost effectiveness than ECDF. As earlier stated, it otherwise just becomes a costly cage and nothing else. If the motion is stopped at the CDR segment, then it of no use. For it to be functional till 14 years, but there is no consensus about it, whether it really function, what kind of implants really function beyond 14 years. There has been an increased use of CDR to extended indications, extended joint arthropathies and all, but still a lot of research is underway. So now the new kid on block is obviously the endoscopic. The last 2 decades this has been the new frontier. There are multiple papers coming up with excellent results for cervical disc replacement endoscopic cervical discectomy versus anterior cervical discectomy and fusion. There is definite long-term outcomes of PECD for soft CDH are comparable with that of conventional ACDF, but with the typical merits of MISS, including rest, reduce operative time, hospital stay, and return to work, what was discussed earlier, there is definite advantage of PECD over the ACDFs and probably also with the ADR. Taken together, PECD may be an efficient surgical alternative for treating this cervical soft disc herniation. Now, again, people are going, there are recent literature available for the anterior full endoscopic cervical discectomy. Though the literature is very scarce, long-term data is not available. Nevertheless, the posterior full endoscopic cervical discectomy is a preferred approach, considering the volume of the disc removal, length of the hospital stay, and the post-operative changes. Though the posterior cervical discectomy is the go-to approach for most of the endoscopic surgeon nowadays, anterior is one approach which requires a further evaluation. All said and done, it is wonderful about great literature that it transforms the man who read it towards the condition of the man who wrote. So you always take this literature with a pinch of salt, see how the literature has been written, how the papers are being written. You cannot really get a homogeneous data with good meta-analysis and level of evidence. That's the reason we are here sitting in a conference hall debating upon the options and still not coming to a consensus. Everyone is right in their own way, in their own experience. Whatever works with you in your own hand for a longer time, it is better to go for that and don't listen to me on this. Thank you for listening and thank you for having me here.